The WHO classification for lung cancer is mainly used for the staging, and it is mainly to kind of accrue patients with a similar prognosis just to deal with the treatment. But the main issue the main, purpose of the WHO classification for pathologies is to be able to classified and to correctly stage the resections of lung cancer that this is one of the specimens we receive into, the specific staging. For that, the most important prognostic factor for the patient is the ability to say that the resection markers are clear. So the international classification, it is based mainly in the T, which is the size of the tumor, in the N, which is the metastasis in the lymph node, and the M, which is the metastasis. So we mainly deal in the specimen with the T, which is mainly related to the size of the tumor, and with the N, which are the lymph node margins. However, apart from these two things that I highlighted, there are other kind of features that we have to look in the resections just to encase the specimen or the lung cancer within one of the stages. As I say in my presentation, the WHO staging classification is a very, very useful tool that we compulsory use in every study we do in the lung resections. And it has been, and it's not kind of a closed classification. It's a very dynamic. And this has been improved, or not improved, but updated with, increase of knowledge. So we have and apart from that, the first one, which was the 2004, was mainly dedicated for pathologists. So this classification we use it just to kind of we rely on this classification to stage the lung cancers. It has been updated in 2015, and it is the improvement has been enormous because in 2004, when we give a report to the clinicians, in many occasions, it was difficult for them to understand. And it was difficult for us to make them understand what we were trying to say when we look at the specimen. So in 2015, many improvements, many updating features were introduced that improved the communication. And this communication nowadays is very important because the essential point that we have to go through every single week in the hospitals are the multidisciplinary team meetings in which we all decide how the patient is going to be treated or has been treated. So, but apart from that, these updating issues, we are still considering, or that there are things that can be improved. So I have selected several what I consider issues that I find in many occasions when I am reporting lung cancers. And they are issues not for me, but it is an issue because it is important that all pathologists we report in the same way. So I have selected some of them, like the resection margin when the tumor is not located in the bronchial or vascular lumen, which is the straightforward thing. We have been used classically, but in this last update, in this last article that has been published, they have included not only tumor in the luminal aspect of the bronchial and the vascular, but also in all the surrounding areas, which means soft tissues and metastatic lymph nodes with extracapsular invasion. The second issue that I try to highlight is the extracapsular extension of the tumor in lymph nodes that are located in the mediastinum that are classified as M2. So in all the articles I could read, I saw that they talk about extracapsular extension, but we have to consider that the M2 lymph nodes are lymph nodes that are resected apart from the tumor. What means that in many occasions we have the lymph node included in abundant fibroadipose tissue. This fibroadipose tissue that implies when you have the extracapsular invasion that is infiltrated, I haven't read any article, just dividing tumors infiltrating the closest fibroadipose tissue to the lymph node, or those tumors that infiltrate the resection margin in those specimens. So I think this is one of the uncertainties that I really, I don't know if they had been studied properly or what I think it is studied properly. The next thing that I consider it is another uncertain evaluation of the lung cancer resection is when we have a tumor that normally infiltrates the periphery, extends to the visceral pleura, so it's a straightforward a PL1, but there is an addition, a fibrotic addition of the parietal pleura, but it is not infiltrated. So the parietal pleura is fibrosed and adhere to the visceral pleura. The tumor infiltrates the visceral pleura, but the resection margin, if you want to consider that, if the resection margin at the surface of the parietal pleura is clear, this is called by authors what is PL1/3 or -3, sorry. And it is a very, not many articles has been written about this issue. And those that I have found, they are not concordant. So in some of the articles, they talk about patients can be considered T2, which is the same that when you have a small tumor infiltrated in the visceral pleura, PL1 is considered T2. And others said that the survival of these patients is similar to those patients with a T3. So I think this is very important just to know how to deal with this, because we are changing drastically the staging system. At the end, I totally agree with the WHO classification. I think that's the best way, because this is an international study, and they are included more than 100K patients. And, it's an international effort, which I think is the only way to go forward. But I think that still there are some kind of uncertainties, or not frequent, but we deal with them quite often, that they are raised in the multidisciplinary meetings, and we just don't really know how to answer.